Hello everybody. Today we're going to be talking about thoracolumbar spine fractures. We want to be able to explain the structure of the spine. We want to be able to understand the AO spine thoracolumbar classification system and categorize injuries within that system. We want to know the variable appearance of what are called compression fractures. We want to predict the mechanism of injury and associated findings based on the mechanism. Broadly, there are three different fracture types in this classification scheme: compression injuries, distraction injuries, and translational injuries. Compression injuries are further divided into minor non-structural fractures, A1 wedge compression fractures, split fractures of the vertebral body, A3 incomplete burst fractures where you have a fracture of a single end plate with retropulsion, and A4, which are complete burst fractures with fractures of both end plates. Distraction injuries, which include B1 transosseous tension band disruption, which is your classic chance fracture. B2 is a posterior tension band disruption, and we'll talk about what that means. B3 is a hyperextension fracture. Translation injuries involve displacement or dislocation, and anytime you have displacement or dislocation, you're dealing with a type C translation injury. Here I've developed a diagram of the motion segments of the spine and what provides stability. The anterior motion segment is primarily made up of the vertebral bodies and the intervertebral discs, and these are primarily responsible for axial loading. The posterior motion segment is made up of the posterior ligamentous complex and the facet joints, and is involved in controlling flexion and rotational forces. The posterior ligamentous complex is made up of the supraspinous ligament, the interspinous ligament, the articular facet capsules, and the ligamentum flavum. So in the diagram, vertebral bodies here provide axial load resistance, and the framework posteriorly of the posterior elements prevent translation of the spine forward, front to back, and prevent rotational motion. Now let's talk about the ligamentous structures that maintain stability of the spine. First, we have the anterior longitudinal ligament running anterior to the vertebral bodies. Then we have the posterior longitudinal ligament running posterior to the vertebral bodies. Then we have the ligamentum flavum, which connect the ventral parts of the lamina of the adjacent levels. This is not just a midline structure, but runs along the length of the lamina. We have the interspinous ligament in the midline, connecting one spinous process to the next. Then we have the supraspinous ligament, running along the dorsal margin of the spinous process. And also not pictured here would be the facet joint capsule surrounding each facet joint. Starting with the A0 minor non-structural fractures, here's an example of a left transverse process fracture, a avulsion fracture, which does not compromise the structural integrity of the spinal column. Next, we have the A1 wedge compression fracture of a single end plate without involvement of the posterior wall of the vertebral body. Also note this malalignment of L5 with respect to S1, that must be due to bilateral pars defects in this patient as an incidental finding. In this next case, we have multiple A1 type fractures of an end plate without a fracture of the posterior wall of the vertebral body and no retropulsion. The question to think about when communicating your findings to the clinician is, which fractures are acute, which are chronic, and which can't you tell? What is critically important is not calling these chronic fractures unless you have priors demonstrating that there's been no change, distant priors. This is how I like to think about this. You have a trabecular network within each vertebral body, and although sclerosis is often taken to be a sign of healing, increased density is not always increased bone formation. Now imagine what happens in the case of impaction type fracture, which is essentially what a compression fracture is. What we see is that the trabecula overlap, increasing the density of the bone. So when you see vertebral bodies that have this appearance, as in the inferior aspect of this vertebral body, the upper aspect of this vertebral body, you can't say that they're chronic. You have to at least say they're age indeterminate. And in fact, you should be suspicious that they're acute. What you can do is correlate with focal tenderness at the site. These patients, if you palpate their spinous process, will be excruciatingly tender at the site of an acute fracture. And an MRI would clear up exactly what fractures are unhealed. This is that same patient. What we see is the majority of these levels are in fact acutely fractured, or at least have not completely healed. Everywhere where this stir sequence has increased signal, we see that these are unhealed fractures. Our next fracture type is the A2 split fracture. These can be quite subtle, as in this case. And these represent fracture of both end plates without involvement of the posterior wall of the vertebral body. Next, we have an A3 incomplete burst fracture. This is fracture with involvement of the posterior wall. Only a single end plate is fractured, and there is mild retropulsion. These can also be associated with a vertical fracture of the lamina, but that does not represent a tension band failure, which we'll talk about later. Now, this is a more obvious case of retropulsion of the posterior aspect of the vertebral body, and you can see this well demonstrated on the axial. But there may be more subtle cases, and the key is to note the normal level will have a concave vertebral body. When you have a loss of the normal concavity, you have to be suspicious of mild retropulsion and disruption of the posterior wall of the vertebral body. The next fracture to talk about is a complete burst fracture, which is fracture with any involvement of the posterior wall and both end plates. Again, you can have vertical fractures of the lamina, but that does not constitute a tension band failure. These types of fractures will often have severe canal compromise, as in this case. The next fracture type to talk about is the transosseous tension band disruption, and this is the classic chance fracture. In the sagittal plane, on the right, midline, and on the left, we have fracture through the posterior aspect of the vertebral body, extending through the lamina, essentially on both sides. And this is defined as a monosegmental pure osseous failure of the posterior tension band. Now, this fracture also has a component of a type C injury with posterior displacement of this segment with respect to the inferior segment. And we'll talk more about type C injuries later. A B2 injury is osseous and ligamentous failure of the posterior tension band together with some type of type A injury. So this would be an A1 injury because there's no retropulsion of the posterior vertebral body, combined with a fracture of the right lamina, ligamentous disruption of the interspinous ligament, given the widening here, probable injury to the ligamentum flavum as well, and malalignment of the facet joint, suggesting a capsular injury. B3 injuries are hyperextension fractures that often go through the disc space. These are most commonly seen in patients with inflammatory spondyloarthropathy, such as ankylosing spondylitis, but can also be seen in DISH. Now, it's important in these patients to establish whether or not the patient has a pattern of inflammatory spondyloarthropathy with ankylosis, or they have DISH, because patients with inflammatory spondyloarthropathy do much worse and are much more frail than patients with DISH. These types of fractures are very unstable. This is a case of ankylosing spondylitis with fusion necrosis and osmosis. There are multiple type C injuries, but they're not subcategorized, and essentially all it takes to get a type C injury is displacement, malalignment of the spine, or dislocation of the spine. In these cases, there's complete disruption of the underlying ligamentous complex, the anterior longitudinal ligament, the posterior longitudinal ligament, the ligamentum flavum, the interspinous ligament, the supraspinous ligament, and the ligamentum flavum, and with or without disruption of the facets. This can, as in this case, result in severe central canal stenosis and potentially cord transection, depending on the severity of the malalignment. These are obviously the most unstable injuries and can result in severe neurologic impairment. And these will most certainly need reduction and fixation. So we've talked about the structure of the spine, talked about the AO thoracolumbar spine classification system, and we saw examples of each fracture type. We've talked about acute versus chronic vertebral body fractures, and we talked a little bit about management with vertebroplasty. One more thing I want to touch on is A1, A2, and A3 fractures can potentially be treated with vertebroplasty and augmentation, and really what you're going to look for in A2 and A3 fractures is what is the degree of central canal stenosis, and that will help you determine whether or not a vertebroplasty can be done to help with the patient's pain. Thank you very much for your time.